Good evening, everyone. I have 5:30, so I think it is time to get started with our educational webinar, Mammograms 101, Everything You Need to Know. My name is Katie Fovell, and I am the State Executive Director here at Susan G. Komen for the New England market, and I'm so glad that you chose to spend an hour with us this evening. I'd like to introduce Regional Vice President for the Northeast, Lori Van Dam, who is going to be leading the discussion this evening. Lori?
Thanks, Katie. Hi, everybody. I'm Lori Van Dam. I am, as Katie said, the Regional Vice President for Komen here in the Northeast. And I'm so thrilled you were able to join us. We love doing these kinds of educational programs, and we have a terrific partner with us tonight. Our friends from Midstate Radiology are going to help us all learn a lot more than we know right now about mammography. So what we're going to do is I'm going to ask each of our panelists to briefly introduce themselves, and then we'll get started. And it's going to be a little bit of a kind of a Q&A format. So I'm going to start by asking Dr. Dye to introduce herself. Dr. Dye, you are still on mute.
There we go. Good evening. My name is Holly Dye. I'm a radiologist with Midstate Radiology Associates and a section chief for women's imaging of Hartford Healthcare Central Region. I've been with the practice about 20 years, and I'm very pleased to be able to join you tonight.
Wonderful. Dr. Spooner?
Hi, good evening. I'm Stacy Spooner. I'm also a radiologist who works for Midstate Radiology Associates. I am section chief of women's imaging in the East region, and it's also my pleasure to be with you tonight.
Wonderful. Megan?
Good evening. My name is Megan Burgess. I'm a nurse practitioner with Midstate Radiology Associates, and I'm the director of their screening and preventative services program. Thanks for having me.
Thanks. Natalie?
Hi, I'm Natalie Pelletier. I'm the Central Region Mammography Manager with Midstate Radiology Associates.
Fantastic. Well, we're delighted you could all join us tonight. And we're actually going to start with Dr. Dye, and she has a few slides, so we're going to go ahead and get started. And Dr. Dye, really where we want to ask you to sort of start is this question you see on the screen. Why should I get a mammogram?
Well, there are a number of reasons, but the first reason is because you're important. You're important, and your health is important. And not just to you, your health is important to your family, your friends, your colleagues. And I know you already do a lot to keep yourself healthy. For example, you eat right. You brush your teeth every day, maybe twice on Sundays. You do a lot every day to keep yourself healthy. And getting a mammogram is just another pillar in the preventative care that you take to make sure you stay healthy. And it's an important pillar. It's also important to know that you're a member of a community of women who take their health seriously, who are positive and forward-thinking, and have a plan to keep themselves healthy over time. There's another reason, of course, that you should have a mammogram, and that's because breast cancer is common and is also eminently treatable. In the United States, breast cancer is the second most common malignancy for American women, skin cancer being the most common. Breast cancer is very treatable if detected early, and in fact, a cancer found early has an expected survival rate of 99% 5 years after discovery. So it's important that we find cancers, and the best way to find them is with mammography. In fact, mammography to date is the only screening test proven to reduce mortality from breast cancer. There are, of course, a number of other breast imaging procedures, including breast ultrasound and breast MRI, but we don't have the 50 years of experience with either of those modalities that we have with mammography. Mammography also picks up little things that other screening tests, potential screening tests, do not. For example, breast MRI doesn't see small calcifications, and calcifications can be an early predictor of a small breast cancer within the breast. Mammography sees those calcifications very well. So not only does mammography have a proven history, it can see things that other imaging modalities do not.
Okay, that's super helpful. Thank you. I didn't realize that mammography had been around for 50 years. That's kind of an astonishing fact, and
It
it
is,
makes
isn't it?
sense that we understand that
Yeah.
we're still using it because it is still so effective. So what should I do to prepare for my mammogram?
Well, some people say you don't need to prepare, but I'm going to go against the grain here and say that it makes sense to prepare for your mammogram because you're going to come in for this test and you want to have the best test, the best quality test you can possibly manage, and you want to be comfortable doing it. So there are things that you can do to prepare that are going to make a difference to your experience in radiology. For example, when we do the mammograms, by necessity, the breast is compressed. It's flattened a little bit for a couple of reasons. One, it reduces the radiation dose to the breast by flattening it because the x-rays pass through the thinner breast more easily and don't stop, aren't trapped within the breast tissue. And second, compressing the breast means that you decrease movement. So it improves the quality of the imaging. The image is going to be better resolved, enabling you to get the best result from the imaging. That compression shouldn't be painful, but sometimes it's a little bit uncomfortable. And there's a feeling of pressure for a matter of several seconds, maybe 20 seconds, while the compression is in place. It bothers some women more than others. If your breasts are particularly sensitive during certain times of the month, then you want to schedule your mammogram to take that into account. So if you're premenopausal and your breasts tend to feel a little fuller and a little more uncomfortable or sore just before your menstrual period, schedule your mammogram after that period. Schedule it maybe 7 to 10 days later when your breasts are not as tender and therefore the compression during mammography is less likely to bother you. If you're sensitive to caffeine, and some people are, your breast can be a little bit more tender as a result. So you might choose to stop caffeine as hard as it is. You might want to give up coffee for a couple of days before your mammogram. And when you come in to have the mammogram done, dress comfortably. Wear loose clothing. You might choose a top and slacks or a top and a skirt because we're going to be asking you to remove that top in order to perform the mammogram. You also want to keep away from using any deodorant, any lotion, or any powder on your breasts or underarms on the day of your mammogram. Why? Because those materials can have a little bit of metal in them, believe it or not, little tiny metal particles that can look like calcifications on your mammogram. And as we said a couple of minutes ago, we're concerned about calcifications. And while most calcifications are benign within the breast, we look at them carefully for evidence of clustering or any evidence that might suggest that these are calcifications of concern. So if you have metal particles as a result of using deodorant, that can confuse us and we can assume those are calcifications rather than something else. So don't use those materials on the day of your mammogram. When you come in, make sure you talk to your mammographer. Express any concerns that you might have about your breast health at that time. Are your breasts sore? Are they sore in a particular spot? Do you feel a lump? Are you having any nipple discharge? Anything else that concerns you about your breasts, either the way they feel or the way they look to you. Share that with the mammographer because he or she will then tailor your imaging to what they've been told, and they will certainly share any concerns you have with the radiologist. If you have any relevant personal or family history that might impact your risk for breast cancer, that's something else that you want to share when you come in, because that will be taken into account not only in reviewing your images, but in planning your future mammogram studies. For example, somebody that has a very strong family history of breast cancer or a known genetic mutation that might predispose them to breast cancer might be advised to have more frequent imaging than a woman with no strong family history or no elevated risk of breast malignancy. Also, if you've had breast imaging done somewhere else, whether it be a mammogram, a breast ultrasound, an MRI, or some other kind of imaging, please inform the staff. We're going to do our best to get that previous imaging in order to compare it with the imaging you're going to have that day. Because if there's a finding, a little something that's asymmetric looks a little different to us. If it's been there for the last 10 years on imaging done elsewhere, we're not going to worry about it. It's a normal, natural finding for you. And again, it's important to remember that you're an important part that is everything done during the mammogram. Mammography is done with you and for you, not on you. So get your best test, prepare for it, and make sure that you're an active participant in what goes on.
I love that statement, done with you, not on you. That's really a powerful way to think about it.
It's true. The woman is the most important person in the room when the mammogram is done. You, the patient, are the most important. You're in charge. So get your best test.
Okay, amazing. So I think we have some slides that are going to show what the imaging system actually looks like. Do you want to walk us through that?
Sure, absolutely. Thank you. So this is a piece of modern mammography equipment. This is the camera. And you can see on the screen that there are some square plates. There are actually 2 of them. So when you have the mammogram, usually you're standing erect when it's performed, unless you have a condition that prevents you from standing, in which case a mammogram can be done in the seated position as well. But usually you would be standing, and then the breast is pulled into the machine gently and placed on the bottom plate. Then the top plate is brought down on top of the breast, and the breast is gently compressed in order to flatten the tissue. And again, that's for 2 reasons: to decrease the radiation dose to the breast, which is very important, and also to decrease any inadvertent movement during the mammogram so that you don't get blurry images. So we get very good, well-resolved images to be interpreted by the radiologist. And anytime we do a mammogram, if it's what we call a screening mammogram, in other words, you're a well woman, you have no current health concerns, no known current or past history of breast malignancy or other problem with the breast, we're going to do a routine screening mammogram, which involves 2 pictures, 2 x-rays of each breast. And exactly, so this is a screening mammogram. And if you don't mind, I'm just going to tell you a little bit about the pictures here. So looking at the screen by your left hand, this is a picture of the right breast and the left breast against each other. And those 2 images are required when the compression plates flatten the breast from top to bottom. And you can see on those images that there are white parts of the picture and there are dark gray parts of the picture. And let me just explain that for a minute. The white parts of the picture are the fibroglandular tissue within the breast, fibroglandular tissue. So that's the milk glands of the breast, the milk ducts, and the supporting tissue around the glands and ducts. The darker part, the dark gray, is fatty tissue within the breast. All women's breasts are composed of fatty and fibroglandular tissue in different proportions. So you may have heard that we'll talk about dense breast tissue. Well, women with dense breasts, it simply means they have more fibroglandular tissue than they do fatty tissue. So in their breasts, more than 50% of those pictures will be white, and less than 50% will be dark gray because they have more fibroglandular than fatty tissue. Whereas women that have fatty breasts are going to have a majority of fatty breast tissue and less fibroglandular tissue within the breast. Okay, the images by your right hand, again, those are a pair of images, right breast, left breast. That's when the mammography machine is turned, the paddles are turned, and the breast is compressed, flattened from right to left, from side to side, using a little bit of a diagonal approach to the breast. And the reason we get 2 pictures of each breast is to incorporate as much tissue as possible in the imaging so that we're sure we've seen everything we can possibly see within the breast. We don't want to miss anything outside the field of view. So at the top of that image, you'll see kind of a white stripe at the top of those 2 images at the right hand of the screen. That's actually muscle behind the breast. That's your pectoralis muscle. And sometimes we'll see lymph nodes, normal lymph nodes, overlying that tissue. And it's interesting because when we look at your breast, we're not only looking at your breast health, sometimes we can see other things on these pictures. For example, in a patient, I don't know, who'd had a recent infection, say, recent infection in the armpit, under the arm, you might see enlarged lymph nodes on the image under that arm. And that would be a way we'd be aware of something else going on. Or we might see calcifications that are not consistent with a cancer, but consistent with vascular calcifications in the breast. And that can be a hint that perhaps this woman has something else going on. Sometimes a patient with coronary artery disease, for example, might present with calcifications on a mammogram in her vessels. So we see not only the breast, but we're looking for other things to give you as much information as possible about your health. So that's a screening mammogram. And I think I have one more slide. Okay, so this, as you can see, is our images of one breast, in this case, the left breast. And there are 3 images of this left breast in the side-to-side compression technique. And this was a diagnostic mammogram. So this is a woman in who there was a small finding in the breast, and we wanted to take an additional look at it. So there are 2 reasons to get a diagnostic mammogram. One is that the radiologist saw something of concern in the image and wanted to take an additional look at it by getting additional imaging of the breast, either an additional projection, additional angle with some more compression in that particular area, or using a different technique, which in this case was tomography. And tomography is when we get what we call a 3D image of the breast by taking x-rays in an arc over the breast with the camera and then reconstructing those images using a computer into a 3D image that allows us to look at slices of tissue through the breast, almost like taking an onion and peeling back the layers of the onion to look all the way through it. And that was what was done here. And if we can just start the cine there, what we've done is taken an extra look at an area just under the nipple of this breast. And if you look really closely, there's a little area that kind of lights up there and is bright white with slightly irregular margins. And if you don't mind just showing that one more time for anybody that might have missed it, that turned out to be a very small cancer in the breast that was suspected on the screening mammogram, but was much clearer on the diagnostic mammogram done with additional imaging targeted to that specific area. We also will sometimes do a diagnostic mammogram if the woman comes in with a complaint. For example, if she comes in and says, I have nipple discharge, it's new and it concerns me. Or I think I feel a lump in my breast. This is where I think I feel it and I'm concerned about it. And then we would take additional images of that particular area of the breast, either with targeted imaging like this, with a little extra compression in the area. We might put a little skin BB, a little marker on the skin to demarcate the location of where the woman feels the area that concerns her, so that we can compare where that area is she feels with what we see on the mammogram. And that's also called a diagnostic mammogram because it's done for a specific reason. Now, if you're called back, suppose I see something on an image of your mammogram and I say, gee, I'd like Suzanne to come back for some additional imaging for a diagnostic mammogram. Does that mean you have cancer? No, absolutely. It does not mean you have cancer. It means we don't understand completely what we see in the images, and we just are hoping for a little more information for clarification. It's just a request for clarification. In fact, most women who are called back for additional imaging do not have cancer. And whether that they're called back to look at calcifications or what we think might be a little nodule in the breast or a little area of asymmetry or distortion, most of those areas turn out to represent normal tissue on the re-imaging. So please don't, everybody worries, but don't worry, don't panic. Getting called back definitely does not mean you have breast cancer.
Thank you. That is so very helpful. I do want to let all of our attendees know that we will have time for a Q&A when we're finished with the conversation that I'm having with our panelists. So if you want to drop any questions that you have into the chat, you're welcome to do that. And now I'd like to turn it over to Dr. Spooner, and I'd love for you to share with us, I know it's a complicated question, but when should we start getting mammograms and how often should we have them?
All right. So absolutely, I can talk a little bit about what that all means. So a mammogram generally consists of 2 low-dose x-rays of each breast. Most facilities offer 2D images with 3D images, also known as tomosynthesis. And I'll just take a moment to talk a little bit about this tomosynthesis concept because I do get quite a few questions on it. If you think of a book and you look at the cover of the book, that's kind of what the 2D image gives you. It gives you a good overview of what the book cover looks like. 3D, though, because it takes several images, actually allows you to look through the pages of the book to get a little more detail on those, as there can be some overlap in the 2D images. Now, 3D imaging can be very helpful for dense breast tissue, and I'll take another moment to talk a little bit about that because it's also another question that I get very commonly. And I'm also reiterating a little bit about what Dr. Dye had already said, but again, I think it's important to understand kind of what you have and what's going on in this area. So breast tissue is made up of fatty tissue and glandular tissue, really 2 things. If you have more fatty tissue than glandular tissue, then your breast is considered fatty. And if you have more glandular tissue than fatty tissue, then your breast is considered dense. Now, the problem with breast cancers is that they are often difficult to see in dense tissue. So if you have dense breast, then certainly mammography is helpful. And tomosynthesis may also be a useful tool to help analyze that breast tissue. Again, thinking of that book analogy. Taking one step further, some women with dense breasts may also benefit from breast ultrasound, which is just another modality that we use to detect cancers, and it works in complement with the mammogram. Now, with that overview, let's talk about timing. As a radiologist, I follow the guidelines issued by the American College of Radiology, which generally states that yearly mammograms should be performed starting in women at the age of 40. Now, other organizations have similar recommendations, usually every other year for the middle-aged patient. Your best approach would be to chat with your doctor because they know your risk factors and they know which option might be best for you. There is no upper age limit of a mammogram, which is another question I get quite commonly. However, if you have significant health issues or things that might really affect your ability to have treatment for breast cancer, then mammography may not be a top priority on your list, and that's perfectly acceptable.
Thank you. That makes a lot of sense. So there are people who have special situations who probably have additional questions about how that impacts their mammogram. I'm thinking about a woman who might be breastfeeding or a woman who has breast implants. How does that impact the mammogram and what a woman should think about when she schedules it?
Good question. So let's talk about a couple of those special situations. So for example, in a pregnant patient, although the risk to the fetus would be considered very small with the mammogram, they're generally not recommended in a patient who is pregnant. Usually when we see pregnant patients, it's because they're having a problem. It's not for a screening study. And typically the modality of choice to image them would be with ultrasound. So mammography doesn't play a role, at least initially, in a pregnant patient. Now, breastfeeding is a different story. Mammograms can be performed when a patient is breastfeeding. And generally, this shouldn't be done until breastfeeding is established. So probably not the first 8 weeks or so. But after that, certainly a safe option. We at Midstate Radiology Associates and several facilities around the area do recommend either pumping or nursing prior to the mammogram, just because that when you're nursing, you can have an increased density to the breast, and doing that prior to the mammogram helps kind of diminish some of that density. And as we talked about before, that can be very helpful for us when we're analyzing the tissue. Now, probably the biggest question I get are for breast implants. So yes, patients with implants can safely have mammograms. The images are performed both including and then gently displacing the implant. It is pretty rare to have a complication from this. There are a couple things though that you can do to minimize this even further. The first one is choose a facility that you're comfortable with and that has experience with implants. The second thing is, if you are having an issue while the mammogram is being performed, please communicate that with your technologist. They're here and we're here to help you through this experience. And if something is uncomfortable, we can easily adjust that or accommodate that to make the experience a better one for you.
Perfect. Thank you. So we all know X-rays give off radiation, and that's an exposure that a lot of us are worried about, and we would just as soon try to limit how much we are exposing ourselves. How should we think about the exposure for a mammogram, and how do I think about the risk of that versus the risk of not detecting a breast cancer if I don't get screened?
Absolutely. Another very popular question. So yes, there is a small amount of radiation associated with having a mammogram. They are in fact low dose X-rays. However, the dose is small. It's less than what we could than a dose that would be for a chest radiograph or a chest X-ray, for example. And it's about 2 to 3 months of background radiation. So background radiation is just the radiation that we receive from the atmosphere from doing our day-to-day living. So overall, the dose is very small. The other thing to remember is the dose is strictly regulated and monitored so that it is kept as low as reasonably achievable. So with that in mind, I like to also remind my patients that the benefits of mammography generally far outweigh any risks. And when patients are still on the fence, I like to add that I really can't remember a patient who ever said to me, gee, I'm really glad I skipped my mammogram the past 5 years. But I do have a lot of patients that have said to me after we found something that was significant, gee, I really wish I had had that mammogram. So there are 2 good ways for patients to minimize their dose if that's something that's still a concern. The first one is once you find a facility that you're comfortable with, try to stick with that facility year after year. And if you do have to switch facilities for whatever reason, please bring all of your prior mammograms. And I hear a lot, oh, I didn't bring them because the mammograms were normal. Well, the glandular pattern for each breast is unique. And as a radiologist, we become familiar with those patterns by comparing them with older studies. So if I don't have prior imaging to look at, I may require additional pictures to help be certain that an area is normal just because I've never seen it before. Whereas if I had seen it, like Dr. Dye had mentioned, and 10 years of mammograms, I would know, okay, this is normal for this particular patient. The other thing you can do, the second thing to minimize your dose, is to inform your technologist of any changes, little things, weight loss, weight gain, skin irritation, larger moles, special creams. You'd be surprised what can show up on a mammogram and what can be confusing for us if we don't have a history to go along with it. So if I see something that I don't have a history to explain, I am going to have to call that patient back to have the additional pictures to ensure that area is normal. But a lot of times, if we get a good history or some information, we can be certain about what that area is, and you won't need to be called back for additional imaging.
That's super helpful. Thank you so much, Dr. Spooner. Okay, we're going to bring up our next panelist, and that's Megan. And there she is.
Good
Hello,
evening.
Megan.
Hello.
So I want to talk a little bit about risk assessment and understanding what your risk for breast cancer is. And we've talked, Dr. Dye mentioned if you have a family history of breast cancer, that's something that you'd want to make sure that your technician is aware of so that they can be thinking about that. But how do we think about what a family history means and a hereditary approach to risk assessment?
Sure. So hereditary risk assessment is evaluating your personal risk of developing cancer, such as breast cancer. But keep in mind, most cancer is not genetic. Most cancer is actually sporadic or by chance. So lifestyle choices, environmental factors, exposures to certain things. Only about 7 to 10% of all the breast cancers that are diagnosed are actually genetic. But it's very important to identify individuals and families with these hereditary cancer syndromes, such as many people have heard of the BRCA gene mutation, so hereditary breast and ovarian cancer syndrome, because we can take steps if we identify these syndromes in patients to prevent cancer, or if it does develop, we're diagnosing it at its very earliest curable stage.
So as a patient, how would I go about getting a risk assessment or having my risk assessed? Is there a questionnaire? Is there testing? Like, how does that work?
Sure. So when coming in for breast cancer screening, for example, your mammogram annually, it's very important to come prepared to provide a detailed family history of cancer. So what type of cancer occurred, personal and family history wise. We do screen genetically for the 8 different kinds of the most common types of hereditary cancer. So that's breast, ovarian, colon, uterine, pancreatic, and prostate. What were the ages of those diagnoses? Was it an early onset breast cancer, young onset? Who are the family members who were diagnosed with cancer? Was it multiple generations? All those details are very important. Also, it's important to identify which side of the family. So maternal and paternal family history is equally important when we talk about risk. I have had the question, well, there's a female cancer on my dad's side of the family, so does that matter? Well, yes, in fact, it does matter, and it does add to your risk, your certain risk factors for developing cancer.
Yes, that is counterintuitive that
Yeah.
even though it's your dad's side, it still impacts you as a woman.
Absolutely.
So if I'm high risk, what does that mean?
So when we look at personal risk factors for developing breast cancer, it not only includes family history, but we also look at your current age, your age at first period, your age at first live birth, your hormonal status, prior breast biopsy history, your ancestry, and of course, your family history. So all that, we've asked those questions year after year when you come in for your screening mammography. Certainly some of those things don't change, but as we get older, our family history typically only gets worse. So we take all of those things into account when we develop what is called your lifetime risk score, or your remaining lifetime risk of developing breast cancer.
And then what do I do with that information?
Sure. Yep. So after we take all those factors into account year to year, we then can determine your lifetime risk of developing breast cancer. So when we, screening mammography, so that's essentially that moment in time till age 85 is considered lifetime. Obviously, we know people live a lot longer now than 85 years old, but if your risk of developing breast cancer is higher than 20%, then we can take steps to lower your risk or screen more effectively for things like breast cancer. So this would include seeing a breast specialist, discussing additional screening modalities such as screening breast MRI. That would be in addition to screening breast mammogram. So that would be done at 6-month intervals. So you'd have each modality performed just once a year, but only 6 months apart. So God forbid something did develop, it would be caught at the most curable earliest stage, which is of course our goal.
Absolutely. Okay, that's super helpful. Thank you so much,
Great.
Megan.
You're very welcome.
I'm going to ask Natalie to join us. Hello.
Hi.
So what should we consider when we're scheduling our mammograms?
So you received so much valuable information already, but I think I have some tips to help. If prior imaging was already done for a patient, I think one thing to consider is the insurance type the patient has. So if it's Medicare, we know Medicare covers a year and a day out. So if a patient had a mammogram today, September 28th of 2021, they would be due to come back for their imaging September 29th of 2022. There are also insurance plans that cover next calendar year. So a patient with that type of insurance that came in September 28th, 2021, they could actually come back in August of 2022 if they were going on vacation. So I think it depends on the insurance and knowing what your plan covers. Another thing to consider is right now with COVID, patients that have COVID vaccinations, the CDC recommends that they hold off on screening breast imaging for 4 to 6 weeks after that COVID vaccination. The body's normal response to vaccinations at times is to have some swelling we found in the axillary region, and waiting the 4 to 6 weeks would just allow the body to go back to its normal state. If it has been determined that a patient has dense breast tissue, it may be recommended that a patient has a breast ultrasound along with their screening mammogram. So that is something they can consider when they are making their appointment for that screening imaging, maybe correlating both to have them done together. If you are having any type of issue with your breast tissue, then that is something that you would want to let the scheduler know when you are making your mammogram appointment, just so that the correct imaging is scheduled for you. There are also different types of breast facilities that you can schedule your mammogram. So there are outpatient facilities and there are also hospital-based facilities. An outpatient facility can look like a center that offers screening breast imaging, where a patient comes in, they have their screening imaging done, and at some point that day or the next day, electronically or by letter, a patient would receive their results. There are also centers that are outpatient based that offer diagnostic imaging, where a radiologist would be on site and would look at those images live while the patient was there. Hospital-based centers are a little bit different, and they would often be the facility that would have a comprehensive breast center. And the comprehensive breast center would offer screening mammograms, diagnostic mammograms, breast biopsies as needed. At our facilities, we have 2 comprehensive breast centers that we do offer same-day reads. And if there is a finding, a patient could speak with a radiologist, can speak with our women's health coordinator, have a consult set up same day with a breast surgeon, and have that biopsy done the same day. So it depends on the timing, it depends on the patient and what the patient is looking for and what their needs are, but there are different options for breast care facilities.
That's super helpful. Excuse me.
Sure.
So my next question actually is also going to address a question that I'm seeing coming up in the chat around the cost for mammograms. Now, we know that we've just heard from you about how insurance thinks about how much time you need to have in between. But we know also that there are some differences in the way insurance looks at a screening mammogram versus a diagnostic mammogram. Can you walk us through that?
Sure. So a screening mammogram is considered preventative, and most insurance companies cover screening mammogram because what we're really saying is the patient isn't presenting with any type of issue. There is no issue, and we're doing a mammogram to make sure there's nothing underlying that the patient is unaware of. And so that would be covered by the insurance company. A diagnostic mammogram means that either a patient presents with an issue or a radiologist review their imaging and they see something that requires additional workup. And at that point, an insurance company could vary on what the coverage is, a deductible, or what type of plan. So we always recommend to patients that they check with their insurance provider because there's so many different plans. It would be difficult for a facility to know what that plan covers. A facility could offer a patient a CPT code so that they can let the insurance company know exactly what imaging is being recommended. And then they can determine with their insurance provider what the out-of-pocket cost would be if there is any.
Got it. Thank you. And if I want to get my mammogram, do I have to get my general practitioner to schedule it? Can I go directly to the facility? How does that work?
So for a screening mammogram, there are many facilities that will take patients and they'd be considered self-referred. So a patient that moves or a patient that doesn't have a provider, but they want to get their screening imaging done, a mammogram could be performed without an order from a doctor. If there is a finding from that screening mammogram, or an ultrasound is recommended, diagnostic workup, anything that's recommended beyond a screening mammogram would require a doctor's order. So facilities that take self-referred patients will most often, like we do, we will help the patient find a provider to make sure that we can get that order for them and make sure they're taken care of. Because that diagnostic imaging, we want to make sure somebody is following them.
Got it. Makes sense.
Sure.
Okay, well, thank you. So I'm going to ask the rest of the panelists to pop back on camera, and I'm going to encourage our attendees, if you have any questions at all, please do drop them in the chat. Does anybody have anything else they want to make sure we tell the folks on the webinar tonight? Okay, attendees, no questions? Anything that you're dying to know about mammograms or screening or MRIs and ultrasounds that we haven't covered tonight? Okay, so we do have one question. If my prior mammograms are done out of state and I'm having difficulty obtaining them, what can I do? Dr. Spooner, you want to grab that one?
Absolutely. As soon as I find my unmute here.
You did it.
I did. So most imaging facilities, I know ours especially, we are very good at being detectives. So if a patient comes in and says, I cannot find my mammograms or I'm unable to get them, we have dedicated staff members who can call a facility and usually orchestrate that very nicely. The only caveat being if the mammograms are very old, let's say 10 plus years old, that may be a little bit trickier because they're often on film and they're not kept, not required to be kept in such a secure place. But we often can find things that we need to do the comparison necessary.
It's almost like it sounds like a translation problem where, me as a lay person trying to talk to them versus your folks talking to people who speak the same language and understand what they need. That might be a much better way to resolve that. So I think that's super helpful advice. Thank you.
I think one more that I saw, and Natalie, you did touch on this, but I just want to go over it one more time, is once my, once the mammogram is done, how do I obtain the information from that mammogram as the patient?
Sure. So a letter will be sent. It is mandated by the accrediting body of all facilities that a letter is sent to patients. So they will definitely receive that letter. Their referring physician will receive the report. And then also we have radiologists that are willing to provide results to patients as well.
Thank you so much. And I see another one just came in. If you have dense breasts and an ultrasound is recommended, is it better to have the mammography and ultrasound at different times to have a greater span of time in between, or is it better to have them closer together? Dr. Dyed, would you like to take that one? Don't get stressed. Please did it.
That's a very good question. That's a very interesting question because different doctors handle it different ways. And in fact, we have some women, because of convenience factors, often will have the mammogram and the breast ultrasound done on the same day. So there's a little bit of an advantage to that because you're looking at the same point in time for the mammogram and the breast, and you can compare the two very easily. On the other hand, some doctors order the breast ultrasound 6 months after the mammogram, thinking, well, gee, if something were to develop in between, we have a chance of catching it. So I don't think there's a right or wrong answer there. At all. I think you can go either way. I don't know that I would want to go more than 6 months in between, but some people do that, and I think that's not a bad idea, actually.
I did actually see another question that would be great for you to answer, Dr. Dye, which is what type of symptoms should prompt us to get a mammogram regardless of age?
Regardless of age. Anything that concerns you. I think one of the great things is that over many years, and with the help of organizations like the Susan G. Komen organization, there's a great deal more of awareness of breast health in the general population of the United States, and specifically within women. We're all more aware of that health. So if you're looking at yourself, and they used to say you should palpate, you should touch the breast once a month in the shower and look for something that way. And you may choose to do that, but just look at yourself in the mirror. And if you notice a change in the appearance of the breast that concerns you, come for your mammogram, come early if necessary. If you feel a lump in the breast that hasn't been there in the past, come in. If you have nipple soreness, nipple discharge, scaling, peeling around the nipple, come in for a mammogram. Basically anything that is unusual, different, or that concerns you, breast swelling, breast soreness, pain, localized pain, come in. It doesn't hurt to come in.
Perfect. I do see one more question that I'm going to throw to Dr. Spooner, which is the question of why am I not supposed to wear deodorant the day I get my mammogram?
I'm still on. Yes, I think so. All right. So again, just deodorant can be a little bit tricky, as most deodorants have little small metal particles in them, which will actually show up on the mammogram and sometimes can be confused for things like calcium deposits. So as Dr. Dye talked about, and as I talked about, the last thing you want to do is get called back for additional images that aren't necessary. So that risk from the deodorant is just, it obscures tissue that we need to see. And sometimes it's hard to tell if your deodorant has the metal components or not. So safest to assume that all deodorant does, and just not wear it that particular day, because we wouldn't want anything to obscure analyzing the breast tissue.
You can put it on as soon as the images have been taken.
Absolutely.
Throw it in your handbag and whip it out when you
And
get
we recommend that.
Fantastic, thank you. I think that covers all the questions that we had from our attendees. So I will take this opportunity to thank our wonderful panelists from our friends at Midstate Radiology again. And all of you who attended this evening, thank you so much for joining us and spending this time with us. As you saw, this is also recorded, so it will be available for anyone who wasn't able to attend this evening to get this really important information. So thank you all so much. Have a wonderful rest of your evening, and we'll see you all soon. Have a
Thank
good
you.
night.